I'm absolutely thrilled to introduce two colleagues and friends today, Dr. Jerry Sigudla for the South African Department of Health. Dr. Sigudla is the Provincial Director for Health Research, where he drives an ambitious programme of reform in research governance. Dr. Jerry's own doctoral research is now being implemented in a model to drive partnerships between researchers and decision makers, advancing whole systems approaches to how we generate and use evidence. Most recently, Dr. Jerry developed a research ethics committee status for the Provincial Health Research Committee, giving the committee more teeth to drive the accountability of researchers to local contexts, as well as driving fairness and respect for persons, fair benefit in populations, and as I said, ensuring the accountability of researchers to local contexts. We're also joined by Maria van der Merwe today. Maria is a former senior government official for the Department of Health, as Provincial Director for Maternal, Child, Women, Youth, Health and Nutrition. Maria drove Systems Thinking's initiative, where she substantively reduced severe acute child malnutrition in the district by embedding evidence in practice. Maria is now an independent consultant and works internationally with the World Health Organization, with UNICEF, and with non-governmental and civil society groups. Maria is also a co-investigator on the VAPOR programme, expanding the evidence base for action on health equity, both in Limpopo and Mpumalanga province. Maria is a senior fellow at the School of Public Health at the University of the Witwatersrand in Johannesburg, an associate fellow at the Centre of Health Data Science, and the president of the South African Dietetics Association. I'd like to make a few words on South Africa as well. Nearly 3 decades after the brutal apartheid regime, post-apartheid societal progress is stagnating. And in 2022, South Africa is the most unequal country on earth. More than half the population lives in poverty, unemployment is 35%. A generation after its emergence, HIV prevalence is 40 to 50 times that in black populations to that of white. Entrenched social inequalities notwithstanding, the democratic order was and is committed to progressive development, health equity, and participatory governance. The country has significant intellectual capital, as we saw in COVID, as well as expanding research infrastructure, not least of which through health and demographic surveillance, supporting and supplying health systems with routine population health surveillance data. It's been a real privilege to work with Jerry and Maria, and Dr. Herod Hosen is also here with us from the district specialist clinical team. And we've worked together now over 10 years, during which we've compared ideas, deepened partnerships, dialogue and exchange about how to do better with that familiar no-do gap. Indeed, Jerry and Maria are here in Aberdeen this week to engage with our health board, with NHS Grampian, around learning health systems and addressing health inequalities. So from the Aberdeen Centre for Health Data Science, a unique centre of gravity here in the northeast of Scotland, embedding data-driven learning health systems, welcome, a warm welcome to you both. We look forward to hearing from you. So, Dr. Jerry, over to you. The floor is yours.
Thank you very much, Dr. Lucia. If we talk about the background of South Africa, I think she has covered it nicely. She presented it well. I'll look at the research in Mpumalanga province. The concept of research uptake that she's talking about, the challenges that we have as government, and then introduce also the model that we are trying to develop to in order to improve research uptake. So Dr. Lucia has been with us throughout this process when we are developing this. Yes, tremendously helped us a lot in order to develop this model. I don't know how many of you have been to South Africa. Mpumalanga province is found in the eastern side of South Africa. I don't have a pointer. In the eastern side of South Africa. So we are sharing borders, international borders with Mozambique and also with Swaziland. The reason why we like to mention this, Donald Trump will say that you have to build a wall. But in South Africa, we don't have a wall. So normally, when you do your planning, we don't even filter what is happening here. These people will just skip the borders to come and use our health services and go back to their countries. When there's social grant, they will come and social grant and then go back to their countries. So planning is really difficult. That's why we need research to be conducted timelessly in our country. So we are a population of 4.7 million people, which is 7.8% of the country's population. We've got 320 health facilities in Mpumalanga province. Plus, we do also have mobile clinics to assist further with regard to providing health services to the communities. Only 44% of the population in Mpumalanga lives in the urban areas. Mostly we are residing in the rural areas. So the HIV prevalence, she talked about it, for all the ages, we are at 17.3%. So we do have challenges as well. Our life expectancy is 64.5 in the country. And then the leading cause of death in Mpumalanga province, it's TB. Is tuberculosis. So if you can look at the HIV prevalence among pregnant women that we normally do each and every 2 years, it is currently at 34.1%. It has gone down from 2017, but for over 10 years or 15 years, it has been around 34%. So it's still a challenge. It's a lot of challenge. And then TB, treatment success. We are at 81.4%. Our target is 90%. So these are some of the challenges that we are facing as a department. The reason why I'm bringing this is that you'll see that there's a need really for research in the province, because time and again, these are some of the things we've been battling. So each and every year, when we do our planning, when we do our reporting, you'll find that we are struggling with this kind of indicators. So neonatal deaths, our target is 9.4. We are at 11.2%. So in 2016-17, it was 9.5. Now we've gone up. Instead of us improving, we are actually increasing in terms of neonatal deaths. Mortality as well is one of the problems. Look at what's happening. Our target is 70, but we are at 140.3 per 100,000. So our life expectancy is around 65% average. But our target in terms of the Vision 2030, it's 70 years. So which I think we are on track to improve on that. So COVID did not spare us as well as a country. We're the most affected country in Africa. So I think 30%, about 35% of the cases of COVID in Africa were in South Africa. As you can see, the total confirmed cases were 4 million in South Africa. And we have lost about 102,000 people during that period. So this really affected, the provision of health services within the country and also within the province. So, but my particular interest is more on research. This is just the background of what's happening, so that my interest is in research is whether the research that we are doing, are we able to translate it to policy and practice? are we able to improve the services that we are offering in the research that we are doing?
Welcome.
So in 2017, there were about 82 studies that were conducted in Mpumalanga province. For the whole year, only 82 studies were conducted. On average, the province normally approves about 65%, 65 studies per annum. So it was only in 2021 where we went up to 82%. So, but you can even see in this figure here that most of these studies that we are talking about here are done by students. So look at government, where we are as government, it's only 2%. We've got the high learning, high institution of higher learning at 20%, and then organizations at 17%. So, but the question is, whatever they're doing here, the students, what the students are doing, does it translate into practice and policy? That's our concern. So if we try to map it with our research priorities, the previous research priorities, you can see that most of these studies were basically on chronic diseases, and then followed by communicable diseases, health system strengthening. I've indicated that we've got more problems in terms of maternal and neonatal. But look at what's happening in terms of the studies. It's 7%, which of course, if then it is translated into practice and policy, it's something else. But then the question is now, are they doing it? That's where we came up with the concept of basically starting to investigate what is it that we can do in order to improve research uptake. So the concept of research uptake has been defined as a process by which knowledge generated through research enters the domain of the audiences, such as practitioners, scholars, and users, policymakers in government and other agencies. So it actually embodies a holistic approach to conducting research. So what was happening in the past is that people will come in to the province, and we give them approval to conduct research. Once they're done with their studies, then they go. Even if they bring those studies, they were doing those studies by themselves, you find that there was no one even who was involved from the department. So how do we trust those kind of studies for implementation? It's difficult. So the doctors will always talk about trust. Do we trust them? Do we trust the researchers? Because normally researchers will come and do whatever they want, and then from there they leave us with those kind of questions. So the reason why we came up with this, we wanted to change this basically. We wanted to say, as government, what is it that we can do to bridge that gap between researchers and policy developers or the practitioners. The good example of this on how to do this is a study that was done by Dr. Lucia, which is called VAPOR. It actually gave us a model on how we want research to be conducted in the province. So when she came in, she invited several people, the stakeholders, the clinicians, all of us. We have been in one seminar, and then she was presenting it. I said, no, this is actually what we want as a department. So while I was doing this research uptake study, we found that there is a discussion paper that indicated that out of 1.5 million peer-reviewed articles, 85% are not cited, which leaves only 15% which are cited. So, citation, it's normally used in institutions of higher learning, in universities, to check the impact of research. With us, we don't use citation per se, but we want to see it translated into practice and policy. So if 15% is only the one that is cited, what does that mean to all the amount of money that was spent in that research? So it goes to waste. So this simply means that potential world-changing ideas are not getting to the public domain. And some of the academics will insist that no, it is not their job to write for the general public. So there was no clear linkage between health researchers and program managers in the department, and the lag between discovery and uptake of new knowledge was also existing. So some of the problems that actually we found when we were doing the research, we found that mainly there were institutional problems. So in our department where I am, we don't have human resources to do research. We don't have enough finances. That is why we rely a lot from the collaboration we have with the University of Aberdeen. So, and previously also management support was not coming okay. But these are some of the things we are trying to change. In our local context, we found that even when research is conducted, I've indicated that it's 85 perhaps per annum. Even out of those 85, you find that the managers, the clinicians, they're not even aware of those research studies. So researchers were not even interested in providing feedback on the research conducted. So, and we also found that there was lack of a champion to lead the engagement among research stakeholders. So there was no proper coordination of research engagement. Another thing was that researchers also failed to align whatever they were doing with the existing local context. So you'll come from maybe a foreign country, you want to do your own thing. You don't even care whether does it basically suit the local context. You know, I received a call, I think it was 2 months ago, from, and I mentioned the name, from London. The person said, no, I want to do research in your province. We said, no, okay, that is fine. You're welcome. Now, give us your proposal and show us your ethical clearance certificate for us to be able to evaluate whatever you want to do. You know the accent of British people. Then he said to me that, no, I won't give you the proposal because we are keeping it secret. So we'll give you after we have done the research.
Sure.
And we'll also give you a donation of a certain amount that you can donate to your own charity. Then we talk of, I said, okay. So of which these are some of the things that were happening. You know, the perspective of this international, that they can just come in there because it's promised us donation. Then we can easily say, okay, come, no, it's welcome. You can proceed with your research. But fortunately, I was able to say, no, it's not happening that way. We don't do it that. Because one of the things that I wanted to do when I was coming in there was that we wanted to stop these kind of things. So where research is conducted without approval, where people were even doing research without even providing us with feedback. So those are some of the things that we are stopping. We are not trying to discourage research per se. No, we are. Actually, I'm also on the side of the researchers. I make sure that I fight for the researchers. So that is why if you come in, you say, no, I want to do research with this, we'll assist you until you are cleared of the local requirements for you to conduct the research. We have never given her any problem. Rather, we are supporting her a lot, you know. Then he could not do it because he could not disclose the proposal. So we also could not even process whatever he was saying. So then he decided to just leave. But those are some of the things that we have been finding throughout this journey of research. So, of course, the other issue was the issue of beneficial collaboration. We didn't have that in the past. So when we developed this model, it's just a simple structure. We could have gone to the internet or to the website and found something from the Western areas that works, but it was difficult for it. It was going to be difficult for us to understand the terms that are used. So we wanted to develop something which we can understand as local people, that we can use ourselves, to improve research uptake. So this is the structure that we developed. It's a simple thing. It simply says that research uptake is a function of the relationship between evidence, context, and facilitation. So what we are saying is that before research is conducted, we need clarity about the strength of the evidence that we need to get. So there's another doctor who likes to talk about trust. These are some of the things that we want to explore. We need evidence, clarity about the strength of the evidence that we will get. Also, the context, the environment in which research is going to be conducted. We need clarity about that as well. So with this, that's why we have developed, we've got the research database, we've got the local research committee. So whenever you come to South Africa, you want to do research, we'll tell you to deposit your studies on this research database. This database will actually require you to upload your proposal and also to upload your ethics clearance. So the guy who called me, you could not pass this stage. This is our first stage, basically. So you could not pass this. And another thing is the ethics clearance. We don't accept ethical clearance from foreign universities. So you actually have to get, maybe collaborate with the local institution in South Africa for you to get a South African ethical clearance, and then before you can even come to us. So which is one of the things that we are working on, to establish our ethics committee so that you will be able to bypass the other institution and come directly to us if you want to do research. So we are trying to promote the conducting of research in our province. So these are some of the things that we looked at in this model, that we should have the research agenda or research priorities for the province development. But when you come in, you know exactly what is it that the province is struggling with. What are the challenges that we have in the province? And then how can you assist us in that? So you don't just come with your topic, then you come, you do your own thing, and then from there you leave, and we still have the same challenges that you might have not even solved anything. So those are some of the things that we want to change. So we are currently working on this process of developing research priorities, and then we also will put in place these strategies. The capacity building strategy, appraisal strategy, communication strategy, and the stakeholder engagement strategy in one of the policies, so that you know as a researcher when you come in that this is how I'm going to conduct myself in this province. Most of the people there might be poor, but we still have to respect them. You can't just come in there, you do as you want because we are poor, we don't have anything. No, we can't allow this. So one of the things that we are doing, we are trying to protect the communities that we are serving as government. Doctor will know that we've got kings there, sometimes in other areas. We've got a king, I think. We also have kings. So you cannot just go to a village of a king and say, no, I'm here to conduct research. There are protocols. We have to introduce ourselves nicely. That is why as government will ask you, have you been to that village? Have you introduced yourself to the king? Before we can even grant you permission to go there. So this is where you are starting. So these are some of the things that I think will make clear in our policies, so that when you come in there, you know that these are some of the things that you need to follow. So we've got the research database as one of the elements, and then we've got also the research committee, which is the structure that basically coordinates the conducting of research. So ultimately, out of this, we want to see improved service delivery. We want to see improved research capacity. In the province, we want to see improved health system in the province. So yeah, like I've indicated that we have started, we want to make sure that we've got, I must accept, we've got broken research system in the province. So it's something that we are trying to fix so that at least we can move accordingly. So fortunately, Dr. Lucia one day asked me, what is it that we can do for you? Hey, Doc, we want to develop our research priorities as it is required in the framework. Oh, okay, I can help. So we have actually initiated the process of developing these priorities that we are going to have for the province. And once are developed, this is some of the things that we'll share with universities. We'll share with stakeholders and say, no, these are some of the challenges that we are in. What is it that you can do to assist us as a province? We have also initiated the process of establishing an accredited ethics committee in the province. We just had our training on the 1st to the 3rd of August, these previous months, and it was also because of Dr. Lucia who supported us by providing that training. So she's actually contributing a lot in Mpumalanga province. I was even thinking that perhaps we can find her side at that site so that she can reside in our province. So basically, we want to appreciate these two universities that are assisting us with the University of Wits University in South Africa and the University of Aberdeen here in Scotland. We are really pleased to be working with you. Okay, so it's a basic structure, but we think if we can do it right, we can improve research uptake in the province. So, but all the suggestions that we have that will assist us, we'll appreciate them. Thank you very much.
Thank you, Dr. Jerry. What a powerful talk, a broken research system. And I know there's huge expertise on our unit about research waste and pushing back against that with things like open research and open science. And hopefully there'll be time for questions where we can exchange and talk more. So Maria, over to you to take a research perspective on this.
Yeah, thank you for the opportunity, and it's an absolute privilege to be here. My second visit to University of Aberdeen, and it's just a joy to be back. With affiliations, just full declaration who and what I am and who I'm working with in some academic context as well as in terms of my consulting. So yeah, I'm not much into signs and all of that, but I am a Libra. So when I was preparing for today, the scale, so am I going to do this? Am I going to do that? What's the middle? Where's my equilibrium? So it was like, am I going to give a lecture on what this is and the theory behind evidence-based management and evidence-based medicines? We know, the medical faculty, evidence-based medicine has over the last 20, 30 years become a talk, evidence-based nutrition, and we established organizations and structures for that. But now we're talking about evidence-based management and decision-making and policies. So I'm not going to go into that academically, but I'm going to demonstrate what Jerry has presented and overall the concept of bringing evidence into policy and practice through two projects that we have been involved with to show the practical application of how that can take place. But just a very short intro, evidence-based decision-making is based on the best available evidence at the time of the decision. And I think that immediately brings a concept of fluidity because it changes over time. So it does mean that we have to go back and review. So it does become a cycle. It's not a one point decision-making or policy evidence being applied. It needs to stay in motion. And also putting the best available evidence from research at the heart of policy development and implementation. That's actually the UK government statement. So from that, what are sources of evidence? And I'm going to give credit to Lucia when we presented to our colleagues in Mpumalanga reaches ethics. So, Lucia, I have toned it down very much. So, pardon, it's not so academic. You'll see the next slide, giving a bit more of an illustration. But what are the sources of evidence? Of course, scientific literature. That's what we are. We're researchers. We publish, although 15% gets published or not published, cited and used again in the academia. But scientific literature, of course, very important. But it's also organizational knowledge. Someone who's been there for 10 years, 20 years, 30 years. They've got knowledge that institutional, organizational, ingrained, that we don't have or someone else may not have. It's also expertise and judgment. In other words, that gut, that no, because I've been there, I've done that. So it is not only something on a piece of paper. And of course, stakeholder inputs. So this would be through whatever form, interviews, surveys, workshops, meetings, focus groups, and we do a lot of those. And we don't do one, we do series. And from that, we have evidence, and that evidence in the next illustration, this is why I give credit to Lucia from our previous work, we would typically, and especially in health sciences, have this hierarchy of evidence. So right at the top, if you have a randomized control trial, that's level A evidence and really the best. Or not even randomized, I'm talking rubbish, better than a randomized control trial. And this obviously came about after I did my undergrad, is a systematic review and a meta-analysis. That's the ultimate. Randomized control trial. And then we go down, right at the bottom, you kind of find case series or reports, and it's always been regarded as being, dare I say, inferior in this hierarchy. So COVID also taught us some lessons, and one of that is that we do not have time to reach this top of this the pyramid, to get to that pinnacle, to say, well, now we have a meta-analysis of what happens. We had to act here and now and make decisions. So even a randomized control trial, impossible. You've got to make decisions now because the world is absolutely in a pandemic state. So it's encouraging us to think, when it comes to evidence and putting evidence into practice, that shift that triangle. First of all, making the lines between these categories. This is a case study, and this was a report and a case study, and then right towards the top, becoming a little bit more fluid and not so distinct. And the interesting concept here is where we take that top part, systematic reviews and meta-analysis, and actually use that to highlight and bring a focus on the other sources of evidence. So relating to my previous slide, to say, what are the sources of evidence? Yeah, scientific evidence, of course, but do not ignore the rest. Organizational, knowledge, etc., as being important. So when we want to shift and saying evidence-based decision-making needs to be part of our core, institutionalize it. It must be part of what we do and how we do when we plan, even when we monitor and evaluate. So as Jerry has also indicated, there are some challenges. On the one hand side, latency between results and uptake, if you even get access to the results, to be able to implement or have uptake, lack of awareness, sometimes poor quality research. I dare not put myself in a triangle of hierarchy and say a lot of undergrad studies, you know, for the sake of a small project that's a literature review or something else, does make up, if you remember Jerry at the start saying the proportion of studies in the province from universities. So that may be undergrad, master, PhD, but a lot of that, I dare say, is for the sake of a qualification. It is to get a master's or a PhD, and that's it. That's the view and the vision that you have. I'm not implying it's wrong, but I'm saying, does that in the end contribute to the bigger picture, as Jerry has highlighted? And on the other side, a relational approach, clear linkages and accountability mechanisms. So this isn't going to happen by itself. We're not suddenly going to have a integration where we have evidence being brought into our processes of management and planning, etc. So what Jerry has done in Mpumalanga province is really extremely exciting, and it is, in my view, groundbreaking to have that through his own study and his own PhD, relevant to his work setting, to say, well, something's got to change. And part of that was relationship, who stakeholders, who needs to be in the room. Relationship also, and through a structure or a mechanism to connect your researchers with your decision makers, your policy makers. And in the end, to have that dialogue and that flow of communication. So this is what we need as the department in terms of information. This is what we want to generate in terms of information or data, and make sure that these two talk to one another. So the first example I want to just refer to is the VAPOR program. So VAPOR is a multi-year program that I'm a co-investigator in under primary investigator guidance by Lucia, and overall learning platforms to connect research evidence on local health priorities with the means for action to enable new partnerships and deliberative processes between communities, government, and research side. So that's quite a mouthful, but if we take different parts there, it's a partnership, it's a connection, it's a learning platform. It brings community, it brings the stakeholder as the department, and it brings the researchers into a picture. So I'm not going to go into the details of the VAPOR project. I think we're more than happy to have another opportunity to do that. We have a website, vapor.org, where you can also find a lot more information. So VAPOR is in first place starting off combining verbal autopsy, quantified hardcore data with participatory action research, total opposite side of the triangle, the bottom and the top bringing put together. So what we did here in VAPOR, we have over time shifted, and it was planned to be fluid and to allow us to move. So I'm not going to go into the details of the process, but we started off with a specific process where we engage with communities and they have priorities. And over time, there's been a shift, and it was what our Professor Witter will always say, organic. It wasn't planned for, it wasn't forced, but it was a shift through our continuous engagement and through the design of the project, which allows dialogue at different levels over time. It has emerged that we need to shift from our initial focus and approach towards an very clearly defined integration within the health system. So although the health system stakeholders have always been identified as a critical component of our VAPOR project, this took it to another level, and I want to demonstrate it through this specifically. So after our first cycle in VAPOR, we had a formal evaluation, sat down with colleagues at provincial level and national level, and at the provincial level, we decided on an official approach where we would have a reciprocal agreement where VAPOR is connected, directly embedded in the health system, and where the health system, different levels of staffing and accountability levels would be drawn directly into the VAPOR program. So after our first cycle, this was a significant shift for us. So at provincial level, right down to community level, we have identified key functions within the operational processes and identified where this will be integrated, because it's a multi-year, 5-year program that has been extended a bit over time, to say, well, if we want to really take this as far as it can go, it cannot be researcher department, we meet in a workshop, you go, we meet in a workshop, you go, to say, right, we are invited into specific structures of the department when the district plan and when they meet, especially also at the sub-district operational level, we are there. Last week, meeting being held with traditional leaders. Normie, can you please, that's our coordinator in the field, can you be there? We want you to be there. And then at the same time, ensuring that our different levels of representative from the department are in the VAPOP process in terms of when we meet. And at that point, it was actually also identified that community health workers, and that's a cadre of health workers almost at the peer support level, working at household level, were identified as the most relevant, and they became the key focus of our remaining 3 cycles. And that was a direct link between the project, the community, and our research project. So this is formally trying to show you the official planning, budgeting and reporting cycle in South Africa. So we don't have to go into too much detail, but oversight by government at parliamentary and legislative level, policies get developed, and then we have this cycle of planning, first of all strategic, then operational, we then implement and report and get going again. So that's the planning cycle within our government. And it starts off with a medium-term strategic framework, which is obviously then also aligned with the ruling party's own 10-year, 20-year strategies. From that, we develop strategic plans at the provincial level, an annual plan, the district health plan, and an operational plan. So it goes from more high level towards on the ground. So by the time you get to operational work plan, we're starting to talk about resources, buying this, using that, training so many people. And then separate to that, but very relevant, is the integrated development plan of our local authorities. But it is intended to flow that way. So we are supposed to start at the reality on the ground and plan from what is happening. At my clinic, I have a low coverage in vitamin A supplementation for children. So I know I need to do something to increase that. Or we have high maternal mortality in the district, we prioritize. And then from that, make the needs flow into the plan of the province. Unfortunately, it mostly happens the other way. So we have targets. National says we want to get to 80% vitamin A coverage. Province says we want to get to 80% vitamin A coverage. District says we want to get to 80%, and the clinic ends up with a target of 80%, irrespective if you're at 30 or if you're at 95. So intention to say plan from operations and reality upwards. I'm going to skip through that one. So when we look at policy and strategy, and again, this is a very complex picture that we, illustration. This is showing the fairly complex reality of the primary healthcare set up in our country, but illustrating again that we have the connection of households by the community health workers primarily. At the clinic, there is a more extended network of health services. Then we have a community health center, which is just a 24-hour, 7 days a week primary care, and district hospitals. But attached to that, we have other services and other structures, the community, the schools, the early childhood development centers, as well as our local government. And they are mostly responsible for our social determinant of health type of services, so water and sanitation, environmental safety, etc. So within that, if you imagine that planning is starting from the top down, it is not taking consideration of any of the realities right here in terms of that clinic. So we have over 300 clinics, I think, in Mpumalanga, 400. Okay, for over 400 clinics in Mpumalanga. So you can imagine if we only plan at a level where targets are set and budgets are allocated. That's another important thing. But the reality for each of those are not taken into consideration. So we need evidence from the ground up, and that evidence, as I said, can be a study, a formal scientific evidence, organizational knowledge. The nurses working there know better than we know sitting in a provincial office, boardroom. I always tell Lucia, we plan in boardrooms. We should be planning on the ground. So what we have, just to very quickly show some opportunities within this planning structure where you have your annual plans and your strategic plans going downwards to operational level. We have formally our district health information system as a source of information, and then also some more program specific, for example, on child mortality or infant mortality. But that is what we base our planning on a health information system that is only based on what happens in a health facility. So anything happening outside of a health facility is not recorded. There could be other resources, for example, from Statistics South Africa. They may have some surveys or household surveys. We can have 4 to 5 year demographic surveys giving you an idea what's going on, but that's not enough. So we need to always consider, in addition to our quantified percentages, rates, etc., that Jerry has demonstrated, we need to also consider the situation on the ground. Just a few things that I've underlined. Baseline performance as a starting point, situation on the ground in terms of our analysis, and also the narrative side. So it's not only saying 5%, 25%, 40 out of 100,000, but the narrative behind that. And that is not found in one source. And then also here, when we report that I have shifted my coverage from 60% to 80%, critical part of that is the narrative review. What is your evidence? Because you may say, I've improved from 60 to 80% because I had this intervention. But we lack the evidence to say, what was it that brought about that change? Because how can we learn and how can we apply it in different settings if we do not also consider what we have as a narrative? And in our reporting system, we have a little column to say it moved from 60 to 80 and this is the reason why or why not, if it didn't realize. But that is very often anecdotal and not based on a core evidence, which I have mentioned can have different sources. This is the research uptake model that Jerry has mentioned. So towards a closure, I've demonstrated in VAPAR how we have this setting, we have the reciprocal kind of exchange where Department of Health stakeholders are formally part of the research process and the researchers are formally part of specific platforms. So the second one I just want to quickly demonstrate from Jerry's whole system model of research uptake. We have recently worked with a master's student at the University of Aberdeen, and credit to Muhammad. He's not in the room, but I think he may be online and soon to graduate. And he has assisted us to also take the concept of these research priority areas that Jerry has identified in the province with specific evidence. I'm going to only demonstrate a very quick example to say, if HIV is a priority, what are you basing that on? What is the evidence? And then actually taking it towards a more specific priority. So the next time researchers come to the research office and say, we want to do research on HIV, Jerry and his team are able to say, these are what we have identified as priorities. Does it align with that? Yes or no? Can we talk about it? Can we be involved early enough in your research planning so that we can shape it towards what we need? Or are you going to come with us with a already developed protocol and you want a rubber stamp to say, go ahead? So that's basically the intention and how we've used data from different sources to say with the team at the department how it can be phrased into research priorities. So overall, involvement of policymakers in the evidence creation process would lead to better implementation. So if the people who need to work with it and plan and evaluate and report are there when we create evidence, it would have a better chance of success. Creation and use of evidence requires connections and exchange, partnership, dialogue. It doesn't happen in a boardroom. We plan in boardrooms, but we shouldn't. Planning has a much larger design. Complexity of evidence can be limiting, so we also need to make evidence relevant and bring it down to what is needed. And it can again start with the design or the sharing of the evidence to make it untie it in a way and to unpack it so that it can be relevant. It doesn't happen by chance, deliberate effort. And that is exactly what Jerry in his setting has brought to the picture. Deliberate effort, a deliberate structure to say this is where we are going to make sure that integration takes place. And evidence alone is not enough. So, of course, it is about the relationships and the bigger picture. And just asking ourselves, what are the consequences if we ignore the evidence? What are the consequences if we turn a blind eye? Closing with a quote, Dr. Sigudla. Generally, researchers produce research evidence that requires end users, such as policymakers and health practitioners, to have analytical skills and clinical knowledge necessary to adopt and implement the research evidence. So you need this skill to make use of it. In this instance, end users become involved in the research project tail end when it's done. Here it is, here's the results. And then we want to publish and get a paper on our CVs and it's done. But ultimately, it renders the process of knowledge translation into practice and policy as an uncoordinated activity between knowledge producers and knowledge users rather than a holistic process. And what we are basically advocating and calling for is that process to be holistic, two-directional, and to be deliberate. Thank you very much.